our last episode of digestive system. We have actually third part. This is the third part. We have discussed about major alimentary canal, starting from mouth to anal canal. Okay. Then the second part was about mesentery and other accessory parts. Now third part, basically we'll talk about liver, spleen, pancreas and gallbladder. So let's start from the very beginning. First of all, liver. Starting from the liver, the Latin word hepato or a heper means liver, and then it is a wedge-shaped gland. Wedge-shaped gland. Yes, wedge-shaped gland, and the color of the liver is a reddish brown color. Then it is a solid organ, having a soft consistency, and it is very friable. And in males, this the weight of the liver is 1,600 gram, and in females, the weight of the liver is 1,300 gram. If we talk about the size of the liver, in male it is approximately 10 centimeter, and in female it is approximately 7 centimeter. Okay, let's discuss about, there are some other important things, exceptional things, that is the largest visceral organ and it is the largest gland in the body. Okay. Then, by birth, this is an exception, that by birth, the size of the liver as compared to adult is 2 times larger. So by birth, this is 2 times larger than the adult. This is size of adult. And by birth, liver carries 5% of the body weight. Okay. Okay, after that, let's discuss about a capsule called Gleason's capsule. It is a capsule, fibrous capsule, which covers capsule which covers around the liver, called Gleason's capsule. It is a fibrous capsule around the liver and is suspended by the hepatic vein and inferior vena cava. Then we have different types of lobes depending upon the category. Physiological point of view, there is 2 lobes basically, right lobe and left lobe. You can see this is the right lobe bigger and left lobe smaller, depending upon the left and right hepatic duct, or you can say bile duct. But anatomical point of view or segmental classification is having 8 segments. There are 8 segments of classification. So physiologically there are 2 lobes only, right lobe and left lobe. But anatomically, as we are studying the anatomy of the liver, having 8 segments. Why this is important? Because by knowing the 8 segments of the liver, you can actually diagnose the actual segment involved in infection or a trauma or a tumor. And while surgery, this 7th lobe or 5th lobe is injured, just resect or remove that segment only. So this is very important, anatomical and surgical point of view. If we divide these 8 segments, I can write the number. This is the first segment, second, third, fourth, 5th, 6th, 7th, and 8th. These are the numbers. It is not like 1, 2, 3, 4, 5, 6, 7, 8. These numbers, please try to remember these segments with the sequence of these numbers only. Okay. According to these lobes also, these 4 lobes and 4 lobes. These second and third segment are called a medial segment. First and fourth segments are lateral segment. 8th and 5th segments are anterior segments. And 7th and 6th segments are posterior segments. So please keep in mind these things also. And if I made few ligaments over here, we have discussed about ligaments in our previous lecture. This is the triangular ligament. This is coronary ligament. Then we have a falciform ligament and ligament of teres, and posterior to this we have ligament of venosum. So and anatomical segments that are 8 in number. And basically, in a nutshell, the right lobe is larger than the left lobe, physiological point of view. Right lobe is 5/6, and left lobe is 1/6. Okay, and in the right side of the lobe, the interior part is also called quadrate nucleus. Quadrate. Q for quadrate lobe, and the posterior part of the right lobe is caudate nucleus. Lobe, not nucleus, lobe. Again, I can remove this and I can show. If I can show you, this is a right lobe, okay, having anterior part and posterior part. Anterior part of the right lobe, it is also called quadrate lobe. Quadrate lobe. and posterior part is called caudate lobe. Caudate lobe. Then after that we have a bare area. Bare means nanga, without peritoneum. Bare area of the liver, that is triangular area which is deprived of, lack of, divide of peritoneum, and is present between two layers of two ligaments, coronary ligament and triangular ligaments. I have told you this is the triangular ligament, and here we have coronary ligament. So between these two ligaments we have a bare area of the liver, divide of, lack of, and deficiency of peritoneum. And what is peritoneum? We have discussed. It is nothing but what is that? What is peritoneum? It is a serous membrane covered by mesothelium. Okay. After that, bare area is present posterior surface of the right lobe. Posterior surface of the right lobe, and in contact with the diaphragm. And what is diaphragm? We have discussed. It's a parachute like a muscle separating the thoracic cage with the abdominal area. Okay. Then after this bare area, the third liver is known as caudate lobe. This is the caudate lobe. It is also called third liver. Why it is called third liver? Because it is having independent of vascularization of bifurcation of the portal triad. What is portal triad? We will discuss. This is duct, like hepatic right and left hepatic duct, then artery, hepatic artery, and vein, hepatic vein obviously. Then okay, let's discuss another clinical things called Riddle lobe. What is Riddle lobe? It is a tongue-shaped downward projection from the right lobe. I can show you from the right lobe. There should be a downward depression like a tongue-shaped downward depression from the right lobe. Some patients, that is called Riddle lobe. Right lobe, left lobe, Riddle lobe, and third liver. And after that we have Porta Hepatis, very important landmark. Porta Hepatis, it is 5 centimeter long fissure. 5 centimeter long fissure present in inferior and posterior surface of the right lobe, and inferior and posterior surface of right lobe. Okay, and the content present in the Porta Hepatis from anterior to posterior aspect, the mnemonic is DAB. You can see D for ducts, left and right hepatic duct, then that is anterior most. And posterior to the duct, left and right hepatic duct, we have A, hepatic artery, obviously. Yes. And then V for vein, hepatic vein, and E for, and we have a epiploic foramen of Visceral. So after this Porta Hepatis, we should talk about dual blood supply. Liver, this is one of the organ having dual blood supply. Lungs are also having dual blood supply. So liver is having dual blood supply. 75% of the blood that is deoxygenated that goes to the liver via portal vein, and 25% of the blood that is highly oxygenated, or you can say rich in oxygen, will go to the liver via hepatic artery proper. So you can see over here we have dual blood supply, 75% via portal vein, that is oxygen rich, and 25% of the blood via hepatic artery proper, that is oxygen poor. Are you with me?
Yes, sir. Yes, sir.
Okay, after this we have hepatic lobule, that is hexagonal in shape. What does mean hexagonal? Chegonal. If I can make over here, हम बचपन में को बेंजीन रिंग भी पढ़ते थे ना ऐसे, वो भी हेक्सागोनल थी ना, लेकिन उसमें कुछ होता, that is hexagonal. So that is it is just like a hepatic lobule, hexagonal shape. This is the structural unit of this liver, and at the corner of this hepatic lobe we have Porta Hepatis, not Porta Hepatis, portal triad, where there is DAB. DAB we have discussed. Yes. From anterior to posterior. Please don't forget this thing. Not posterior to inferior or interior. This is anterior to posterior side. Mnemonic is DAB, D-A-B-E. D for duct, right and left, hepatic duct, artery, hepatic artery, then hepatic vein, then E for epiploic foramen of Visceral. Okay, let's discuss other things like we have 3 zones of liver. 3 zones of liver. If I can show you like this. This is the first zone. Then we have second zone. And then we have third zone. This is the first zone, second zone, third zone, like this. Just giving you a concept regarding this zone. The first zone, that is called Periportal Zone. It is oxygen-rich zone, and this is the zone which is first affected by the viral hepatitis. Whenever there is a virus that will cause a hepatitis, the number 1 vulnerable zone, that is zone 1. Okay. Then we have zone 2, that is also called intermediate zone, not that much important. Then third zone is called pericentral zone. It is oxygen poor, and okay, I can do like this if oxygen poor, because zone 1 is oxygen rich, and zone 3 is oxygen poor. Okay, and it contains a P450 system. You will study this P450 system in maybe pharmacology in your next subjects. So P450 system present in the which zone of the liver? Third zone. And the third zone is firstly affected, or you can say number one target of ischemia, toxic injury, and alcohol injury. If someone is taking alcohol in immense amount of and in many times of frequency, then the first zone that is going to be affected, which zone? Third zone. And ischemia, decrease oxygen supply to the tissue will lead to the which zone? Which zone will damage first? Third zone. Okay. After these zones, we have nervous innervation. Liver gets innervation by a celiac plexus, a branch of which gives a branch called hepatic plexus, and lymph or lymph vessels. Lymph from the liver, from the gallbladder will go to the Porta Hepatis. These, we are talking about anatomy. We have discussed about Porta Hepatis, portal triad, lobes, anatomical, physiological classification. These few small things. Just remember in that way only. Like we are talking about plexus, celiac plexus. It gives the branch hepatic plexus that will innervate our liver. Then we have talked about lymphatics. Lymph from the liver and from the gallbladder will go to the Porta Hepatis. That's it. No need to go into detail right now. Then after this plexus, we have sinusoids of liver. What are the sinusoids of liver? These are the irregular capillaries with fenestrated endothelium. Fenestrated means having holes. Okay, having holes. So it is irregular capillaries with fenestrated endothelials. It is without basement membrane. There is no basement membrane present in the sinusoids of the hepatocytes or liver. And they allow the macromolecules of plasma to the basal surface of the hepatocytes via Kupffer cells. What are the Kupffer cells? These are the macrophages of the liver. Macrophages of the liver are called Kupffer cells. So these names are different. Like macrophages of the brain are called microglia. Macrophages of the liver is called Kupffer cells. Macrophages of spleen having different names. Macrophages of the skin having different names. Then after the sinusoids, we have a space of DC. Very important thing. Space of DC. It is perisinusoidal space. It contains the Kupffer cells. That is enough right now for you people. Then we will talk about some clinical features related with the liver. We have discussed about general anatomy of the liver. We have talked about size, weight, lobes, and their names, innervation, vessels, and all these things, zones. And then now we are talking about clinical features of the liver. Number one thing is portal hypertension. The normal, blood pressure, or you can say portal blood pressure is 7 to 10 millimeter of mercury, obviously in the portal vein. But if there is a pressure more than 12 millimeter of mercury in the portal vein, that is called portal hypertension. We know we have blood pressure. What is the normal value of blood pressure? 120 by 80. 120 means systolic pressure. If that is more than 139, we call it hypertension.
Yes.
But normal pressure over here, that in systemic hypertension, we have 120 by 80 normal.
Yes.
But in portal blood pressure is 7 to 10 millimeter. If the pressure is more than 12 millimeter of mercury in the portal vein, okay, if I can show you about portal vein, all this stuff. Simple, this is what our dear organ, liver. Okay. Then we have a superior mesenteric vein. Then we have splenic vein that is joined with the inferior mesenteric vein. And these two veins, they join together to make portal vein. This is what? Portal vein. So if the pressure present over here is more than 12 millimeter of mercury, that is called portal hypertension. Now it is clear?
Yes, sir.
So portal hypertension, more than 12 millimeter of mercury, or there are some reasons, like if there is a compression by the hepatocellular carcinoma. If there is carcinoma over here, so what will happen? There will be backflow of blood, because superior mesenteric vein getting blood from here, inferior mesenteric artery, then there will be splenic artery, sorry, not artery, vein. Spleen mesenteric vein, inferior mesenteric, splenic vein, they are making portal vein. And if there is blockage over here, what will happen? There will be increased pressure over here, right?
Yes.
So due to this hepatocellular carcinoma, there will be increased pressure in the portal vein that is called, that may lead to the portal hypertension. These are the few causes of the portal hypertension. And needle biopsy. If you want to take a tissue from the liver in order to diagnose any specific pathology, then what you do, you have to insert the needle from the right maxillary, not maxillary, mid-axillary line. So Aliveza Vattu will tell me why we are putting a needle from the 9th to 10th intercostal space, like rib between 9 and 10th rib, intercostal space. What is intercostal? Inter mean between, costal ribs. Between 9 to 10 ribs, intercostal space of 9 to 10 ribs, mid-axillary line of the right side, we will put needle, insert needle that will cross the peritoneal cavity and pleural cavity, and then it will take a liver tissue for biopsy. Why not from the left side?
Because it is right side.
Yes, because location of the liver is the right side.
Right side, yes.
And if we want to take a biopsy of the spleen, we have to go through the left side. So we know these locations. Spleen we are having left side, liver right side. That is why if you want to have a needle biopsy, just put your needle between 9th to 10th intercostal space, right mid-axillary line. What is the mid-axillary line? This is the axilla, right?
Yes.
Mid-axillary line. Anterior axillary line should be here. Anterior axillary line, mid-axillary line, and posterior axillary line. So mid-axillary line, 9 to 10th intercostal space, the needle will pierce the peritoneal cavity and pleural cavity. Then it will take a tissue from
So
the.
it's not a costal groove.
No, we have discussed about ribs, right? Costal groove is present just at the inferior aspect or posterior aspect? Inferior aspect. So, see, this is how things work. If you know osteology very well, then only you can put needle at the right place.
Right. Yes.
Very nice. Okay. So, needle biopsy, right mid-axillary line at the 9 to 10 intercostal space. Okay. Okay, surgical resection of the liver. We can surgically remove the liver, maybe one segment, 2, 3, 4, 5, 6, 7 segments. Or maybe one or more than one segment we can surgically remove if there is any kind of tumor or an injury to the any segment. So again, why it is very important to know all these segments, because if there is a tumor present over here, and if you know the actual location of this segment, you will simply remove this segment only, this segment. Okay, so it is like that. So this is landmark of the surgery is hepatic vein. Hepatic vein will tell you which segment is present where. So landmark of this surgical resection of the liver is hepatic vein. So now we have two types of hepatectomy or hemi. Hemi means half, left and right. Right hemi or right hepatectomy, in which we remove 6 to 7 and 8 segments. Plus gallbladder can be removed. 6, 7 and 8. In left hemi hepatectomy, hepat means hepatocyte liver. Ectomy means removal.
Removal, yes.
So left hepatectomy, we remove 2, 3 and 4 segments. Second, third and fourth. Second, third and fourth segment, or most of the caudate lobe. So if you know these segments, caudate lobe, quadrate lobe, then only you will act like a pro surgeon. So inshallah. Now we'll talk about some transplantation of the liver. Transplantation of the liver, in which we transplant the liver, we remove the liver plus the few segments of inferior vena cava. You know, we have 3 veins that will join together, and they will make now inferior vena cava like this. This is inferior vena cava. It will go to the heart. Okay. So we will not only remove the part of the liver, but also few segment of the inferior vena cava, and donor's suprahepatic inferior vena cava we remove, and it will suture to the recipient, and followed by the infrahepatic caval anastomosis. We will join these things together, and it will lead to the portal venous anastomosis. So this is all about liver transplantation. Now we talk about what is hepatitis. What is encephalitis? Inflammation of the brain. What is carditis?
Inflammation of the
cardiac myocytes or layers of the heart. What is orchitis?
inflammation of
Inflammation of testes. What is salpingitis?
Inflammation of
uterus. So where there is an inflammation, just put a suffix called itis. Hepato means liver, inflammation means itis, hepatitis. So basically there are two things or two causes which causes the inflammation of the liver or hepatitis. One is amoebic hepatitis or one is infective hepatitis. Then we have cirrhosis. Cirrhosis of liver, in which what happens, there is a caput medusa at the umbilicus. What is caput medusa? Caput medusa is nothing but simply abnormal dilatation or tortuous veins around the umbilicus. You can see if the person is having cirrhotic liver. What is cirrhosis? In which there is a liver becomes shrunken and fibrosed. And how you will diagnose, because you are not having ultrasound or any kind of stuff in your eyes, right? You can't see liver. So how you will diagnose now? This person is having cirrhotic liver. You will see around the umbilicus. You know we have umbilicus.
Yes.
Around the umbilicus we have tortuous dilated veins are most commonly visible. That is called caput medusae. This is one of the sign of liver cirrhosis. Then we have another two signs to diagnose this cirrhotic liver. That is, one is shifting dullness, another is fluid thrill. We check these things. You will learn these things in your next classes. We put our hand over here and we just simply do a tap from this side and you will feel a thrill over here. That is called fluid thrill. And shifting dullness. Dullness will shift from left side to right side. And what happens in cirrhosis, basically there is a liver becomes shrinks and fibrosed. Most commonly, the most important factor which causes a cirrhosis, that is malnutrition. And there are some other causes also, obviously. Then after the cirrhosis, liver is the most common site of metastatic tumor. Why? Simply because all the blood from the GIT, superior mesenteric artery, inferior mesenteric artery, and splenic vein, superior mesenteric vein, inferior mesenteric vein, splenic vein, they are carrying blood from the GIT. So if there is a tumor in the GIT, tumor of the stomach, tumor of the duodenum, so as blood is going to the liver, the tumor cells will also go to the liver.
Yes.
Are you with me?
Yes,
So
sir.
that is what is most common site for metastatic tumor. What metastasis mean? Is spread of tumor. Spreading of tumor. So if there is a tumor to the stomach, and from the stomach vein will go directly to the liver first, right? So the tumor cell will also go through this vein, enter into the liver, and will cause cancer over here. That is why it is also called most common site for the metastatic tumor. And because portal vein get blood from the GIT, and if there is GIT having any primary tumor, definitely it will go toward the liver and cause a secondary tumor in the liver. And then resection of primary and secondary tumor, we remove 80% of the mass very easily, and we need 6 to 9 minutes required for the regrowth time. If we resect some part of the liver, so it will take 6 to 9 minutes to start the regrowth process. We know if the person is, one person is a donor, another is a recipient, the donor will take the part of the liver, maybe some segments of the donor's liver to the recipient's liver, so that donor's liver will regenerate itself.
Yes.
It is having that capability. Then after these things, there are tips for the portal hypertension. Normal portal, as I told you, more than 12 millimeter of mercury, it is portal hypertension. And tips, it is the treatment of the portal hypertension. What is tips? It is transjugular intrahepatic portosystemic shunt. Transjugular means you will go through the jugular vein. Intrahepatus in the liver. Portosystemic shunt, you will create a shunt between portal system and systemic system. Portosystemic shunt. Shunt is a connection. We will study in detail later on. So tips for the portal hypertension, but in severe cases of portal hypertension, we give a balloon catheter. We put a balloon catheter, start from the internal jugular vein, superior vena cava, inferior vena cava, hepatic vein, liver tissue and portal vein. Because portal hypertension, what is portal hypertension? It is hypertension in the portal vein only. Na? So we have to go till the portal vein. How we will go direct to the portal vein? We don't know where portal vein, where is portal vein? I don't know. So what we will do, we will start from the internal jugular vein.
Yes.
Jugular vein, see in Quran pa bhi hai na jugular vein ke bare mein shahrag. So we will start from the shahrag. We will start from the jugular vein. Balloon catheter. Jugular vein, internal jugular vein, it will enter into superior vena cava. Superior vena cava enter into our heart, and from heart will go to the inferior vena cava. We are going backward. Inferior vena cava, you can see. This is inferior vena. Now we are coming down like this, and we will go the portal vein. starting from the internal jugular vein. This is the path of this balloon catheter. Internal jugular vein, superior vena cava, inferior vena cava, then hepatic vein, then tissue, hepatic tissue, then portal vein. Okay, this is how things work. That was about neuroanatomy and some clinical features related with our liver. Now we will discuss about spleen. This is the largest lymphoid organ, and there are some splenic statistics. Statistics mean some aakde. Splenic statistics. We have odd numbers like 1, 3, 5, 7, 9, and 11 in order to understand some splenic numbers. How? There is a 1 inch, spleen is having 1 inch thickness, 3 inch wide, 5 inch long, 7 ounces it is the weight, and 9 to 10 this is it present. Spleen is present beneath the 9th and 11th rib, 9th, 10th and 11th rib. Again, these are the splenic statistics in order to understand few landmarks of the spleen.
Yes.
1, 3, 5, 7, 9. These are the odd numbers, right?
Yes.
So 1 means 1 inch
Yes.
thickness.
Thick.
Spleen is 1 inch thick. 3 means wide. It is 3 inch wide. 5 means long, length. It is 5 inches long.
Yes.
7 means weight. It is 7 ounces weight. And 9 and 11 means it is present just beneath the 9th, 10th and 11th. Left or right?
The left.
Left obviously we have seen on the left side. So it is beneath the 9th, 10th and 11th rib. So that are some splenic statistics. In male, the weight of the spleen is 44 to 468 gram. In female, 28 to 15 gram. Then normally spleen is not palpable. There are some examiners, you will have a counter in your future.
Yes.
Maybe they will ask, this person is having a person sitting in front of you and just palpate the spleen. If the person is normal, please keep in mind you can't palpate the liver. ज़्यादा efficiency show नहीं करने के साथ yes I can palpate. वो कहेंगे इसका spleen normal है. तो normal spleen is not palpable. You can't palpate normally spleen, but you can palpate, you can touch, you can feel the spleen if the size of the spleen is double than normal.
Yes.
Okay. So it is not palpable clinically, and if it is enlarged 2 times, then it is palpable and is present left costal margin in the right decubitus position. You will ask the patient to lie down with the right decubitus position, and you will check from the left costal margin. Okay, then we have few borders. There are 2 borders of the spleen, superior border and inferior border. Superior border having 1 to 2 notches, and it separates 2 surfaces. We have 2 surfaces of the spleen, visceral surface and diaphragmatic surface. It is being separated by the superior border. And now we'll talk about some impressions on the visceral surface. In the visceral means andruni, internal surface. There are few impressions, depressions, some landmarks in the visceral surface of the spleen. The mnemonic is GPCR. GPCR. G stands for there is a gastric impression for the fundus of stomach. Then P for pancreatic impression for tail of pancreas. C for colic impression for the splenic flexure, and R for renal impression for the left kidney. So these are few impressions on the visceral surface of the spleen for these things. Please don't forget these things. Then we have a hilum. See, if this is spleen, I can show you. If we have spleen like this, and this part is called hilum. This is the hilum of spleen, and it transmits splenic artery, splenic vein, splenic nerve. And there are few ligaments. We have discussed about these ligaments in our second part of the digestive system. Again, we have a ligament called gastrosplenic ligament that will start from, if this is the stomach, start from the greater curvature of the stomach and going towards the spleen. That is called gastrosplenic ligament. The content in the gastrosplenic ligament is left short gastric vessels and left gastroepiploic vessels. Then we have another ligament called linorenal ligament. What is the other name of linorenal ligament? Splenorenal ligament or linorenal ligament. The content present in linorenal means starting from the hilum of the spleen and going towards the
Left
kidney. Renal means kidney, left kidney or right kidney?
Left kidney. Obviously.
So the content present in the linorenal ligament is tail of the pancreas, splenic vein and pancreatic superficial lymph nodes. Then we have third ligament called Phanikofolic ligament. Obviously it will start from the left colic fissure and going towards the diaphragm. Phanikofolic ligament. It prevents from the downward displacement. It is also known as sustentaculum lenis, another name of Phanikofolic ligament. Then we have, okay, if there is a splenic rupture, spleen is very vulnerable to rupture. If someone in fight or in accident, if there is any injury to the left side of the thorax or left costal margin, then spleen is most commonly organ to be ruptured. So if there is a rupture of the spleen, we have two types of surgery: partial splenectomy and total splenectomy. In partial mean incomplete.
Yes.
In partial splenectomy, we will remove some segment of the spleen.
Yes.
But in total splenectomy, we will remove all the spleen. So in order to do this splenectomy, please save tail of the pancreas and splenic vessels before cutting the linorenal ligament. Then we have another clinical things like spleen is movable. During inspiration and expiration, the spleen also moves. So then we have, okay, spleen plus liver. If there is a enlargement of the spleen, what we say? If there is a spleen is enlarged, splenomegaly. Splenomegaly.
Yes.
If the liver is enlarged, hepatomegaly. If the heart is enlarged, कहते हैं उसका दिल बहुत बड़ा है. इसका मतलब ये नहीं कि उसको कार्डियोमेगाली है. इसका ज़रूर बड़ा है. तो if we talk about size of the liver. Size of the liver, male and female we have discussed. More than normal, hepatomegaly. It will go to the right iliac fossa.
Yes.
See, liver is present over here.
Yes.
If the liver becomes enlarged more than normal, it will go to the right iliac fossa.
Yes.
But there is exception that the spleen is present in the left side. But if there is splenomegaly, it will also go to the right iliac fossa. Why? You can see. If the splenomegaly or hepatomegaly, it will go to the right iliac fossa. Okay, liver is common. It is present in the right side.
Yes,
If there is enlargement of the liver, it will go to the right iliac fossa. But spleen, why it is going to the right side? Because due to the Phanikofolic ligament. Due to Phanikofolic ligament, attachment from the left splenic flexure to the diaphragm, that is why spleen don't go to the left iliac fossa, it will go to the right iliac fossa. If I can show you over here in a very rapid way, we have hepatic flexure, then splenic flexure. This is splenic flexure, right? This is splenic flexure, huh?
Yes.
There we have spleen present over here.
Yes.
As I told you, we have ligament called Phanikofolic ligament. As I told you, phrenico mean diaphragm. Diaphragm gets innervation by the phrenic nerve.
Yes.
So where there is a name comes phrenic, it means diaphragm. Then colic means colon.
Yes.
More specifically, left flexure. From the left colic flexure, it will go to the ligament, will go to the diaphragm.
Yes.
So if there is enlargement of the spleen will go to the right iliac fossa. And we have liver over here, obviously. This is the hepatic flexure. So if there is enlargement of the liver, that will also go to the right iliac fossa. Is that crystal clear to you people?
Yes.
Okay. अगर question हो तो बाद में पूछ लेंगे. Then last but not the least, it is most vulnerable of trauma in the left thoracic cage, especially the 9th, 10th and 11th rib. It is most vulnerable to trauma. If there is any damage to the left 9th, 10th and 11th rib, the stomach is spleen gayi.
Yes.
So the spleen is most vulnerable if there is a trauma to the left costal surfaces, especially 9th, 10th and 11th rib. So that was about spleen. Now we will discuss about our pancreas. That is also called organ of romance. Why? Why, Vatuji? See, you can see over here, this is the head of pancreas and it is being covered by this duodenum like this. So this due to this close proximity, closeness, ज़्यादा नज़दीकियाँ, that is also called organ of romance. In order to, that is, I'm not telling this thing to why because I'm a very poetic, just to keep these things in your mind very clearly.
Yes, sir.
So okay. The pancreas, it is 5 centimeter long and it is having endocrine part and exocrine part. We know endocrine system. It releases insulin, glucagon, and somatostatin, alpha cells, beta cells, and delta cells. Beta cells of pancreas, specifically islets of Langerhans, present at the tail of the pancreas, will release insulin, very responsible for our glucose metabolism. Then we have exocrine part, it releases some lipase, amylase for the digestion purposes. If there is a problem to the endocrine part, there will be diabetes mellitus. If there is a problem to the exocrine part, there will be digestion disturbances. There is a problem in the digestive system. So okay, in males it is 70 gram, in females the weight of the pancreas is 60 gram. And if we talk about the parts of the pancreas, first of all, head of the pancreas, It is present at the level of L2. It is hook shaped and it is having extension upward. And another thing which is having lateral extension, that is called uncinate process, we will discuss over here. You can see this is the head of the pancreas. Then we have uncinate process. Then we have neck of the pancreas. From the neck to tail, we have body of pancreas, and here we have tail of pancreas. Is that easier for you? Then we have some relations of the head of the pancreas. Anterior, posterior, superior, inferior. Relation means what is present anteriorly, posteriorly, and other things. Anterior to the head of the pancreas, we have D1. What has been D1? First part of duodenum. If I can show you, this is the D1, D2, D3, and D4. So anterior relation of the head of the pancreas, D1, jejunum and transverse process. Posterior relation of the head is having a renal vein, inferior vena cava, common bile duct. And if there is a tumor to the head of the pancreas, it will cause jaundice. Why? Because tumor of the head of the pancreas will compress the common bile duct. If I can show you over here. Okay, let's remove again this thing again. Common bile duct. See, this is, I suppose this is our liver. Again, our largest part. The left hepatic duct and right hepatic duct. This is common hepatic duct. This is cystic duct, this is gallbladder. This is left hepatic duct. That is right hepatic duct. And that is what? Common hepatic duct. This is what? Cystic duct. Cystic duct and common hepatic duct, they join together and make what? Common bile duct. This common bile duct and main pancreatic duct, they will join together. This is what? Main pancreatic duct. They will join together to make what? Hepato-pancreatic duct or ampulla of Vater. They will drain into the second part of duodenum, that is called D2, with the help of a sphincter called sphincter of Oddi. Sphincter of Oddi. Okay, come back over here again. We are talking about the relationships. So if there is a head of pancreas, tumor of the head of the pancreas that will compress the common bile duct, it will cause jaundice. You can see over here, this is the common bile duct. If there is a compression over here due to the tumor of the head of the pancreas, so obviously we are having jaundice. Blue discoloration of our sclera and mucous membrane. See, we check sclera from our, we check jaundice like this. Okay, if we want to check the anemia, what we will do?
Sir,
you will do like this.
check
And in order to diagnose the jaundice, you will do like this.
Yes, sir.
So if the person is having jaundice, you can see the blood bluish. It is yellowish. Yellowish coloration. Now you can see, hopefully I am having white sclera.
Yes.
But say in jaundice patient, that white becomes yellow. And here we can check anemia. This is anemia and this is jaundice. Due to some biliverdin, other bilirubin things. Okay, then we are having superior part of the head of the pancreas relation with the D1, like first part of duodenum, then inferior part related with the D3, third part of the duodenum. Then we are talking, okay, uncinate process. This is the uncinate process, having anterior part and posterior part. Anterior part related to the superior mesenteric vein and posterior part related with the abdominal aorta. Then we have neck of the pancreas. Okay, after the uncinate head, we have neck of the pancreas present at the level of L1 at transpyloric plane. It is having anterior and posterior part. Anteriorly, there is presence of pylorus, gastroduodenal artery, and posteriorly related with the portal vein and formation of portal vein, obviously. Formation of portal vein present in the posterior part of uncinate process. This is the portal vein, posterior part of the uncinate process. So these things are interrelating with each other. Okay, after this process, let's discuss about the body of the pancreas. It extends from the neck to tail. You can see over here. This is, okay, I can show you again. Okay, I will do this. This is the head of pancreas. Here we have uncinate process, that is neck, and here we have tail. So extend from neck to tail. What is this? Body. This is body. So body extends from neck to tail, and there are three borders: anterior border, superior border, inferior border, having three surfaces: anterior, inferior, and posterior. In anterior surface of the body of the pancreas, we have stomach and lesser sac. We have discussed about lesser sac and greater sac, right?
Yes, sir.
So if I can show you again. Lesser sac attaches with the lesser curvature and with the liver.
Yes.
And greater sac start with the greater curvature with the colon. So, yes?
Yeah,
Okay. Gastroduodenal?
Gastrospleen fracture.
Gastrosplenic and gastro. Okay. These things we have discussed in our first and second part of digestion. If you have any problem, you people kindly listen and watch these things first and second part again. So now we are talking about the last part of digestive system. Okay. The inferior surface of the body of the pancreas having left colic flexure and duodenojejunal flexure. This is the flexure. What does mean flexure? Bending, simply bending. This is our large intestine. This is hepatic flexure, and that is splenic flexure. Bending, because we are having spleen over here and liver over here.
Yes.
So flexion in bending. So duodenojejunal means duodenum and jejunum, between jejunum we have duodenojejunal flexure, where there is the presence of ligament. Which ligament is present between duodenum and jejunum? Ligament of Treads. Ligament of Treads. That is hallmark for the upper GAT bleeding and
lower GAT bleeding. Yes, sir.
What is the hallmark of upper GAT bleeding? Bloody vomiting, hematomesis. And lower GAT bleeding? Bloody is also called melena. M-E-L-E-N, melena. Then we have posterior surface of the body of the pancreas, splenic vein, and abdominal aorta, superior mesenteric artery, left kidney, left renal vein, left kidney again, left suprarenal gland, and left crus of the diaphragm. Okay, after the body we have tail. It is the most mobile part of the pancreas, and it is having maximum number of islets of Langerhans. That is the most important thing for the exocrine function of the pancreas. This is the tail. It is having maximum numbers of islets of Langerhans. This is the tail. Yeah?
1 to 2 millions.
Okay, 1 to 2 millions. On average, okay? And it releases which? Insulin. Oh, no, not only insulin, insulin also, glucagon also, somatostatin also, because, okay, we will not write insulin. And if you are doing spleen, we have, with the tail of the pancreas, we have spleen like this. And this is the most important thing you should not forget as far as you are a good surgeon. Because mostly surgeons, what they do, while removing the spleen, they also remove the tail also. So this is the complication of splenectomy. And I believe you are a very good surgeon. Now you know nothing. You will not even touch the tail of the pancreas. You will go to your target like a bullseye, and you will do that. It will have a good prognosis. Okay. Tail, which is the most mobile part, having maximum number of islets of Langerhans. That is the most common splenectomy complication. Splenectomy. Okay? That while removing the spleen, involuntary or in spite of having knowledge, or maybe there are some reasons, they may remove the tail of the pancreas. Okay. And tail, it enters at the hilum of the spleen and the renal ligament. Attachment is also there, renal ligament. Okay, now we will discuss about some blood supply of the pancreas. It is having pancreato-duodenal artery, which supplies the superior part and inferior part. Superior includes head of the pancreas. And we are having splenic artery. Splenic artery gives blood all of the pancreas except head. And as we know, head getting the blood supply by the pancreato-duodenal artery. And then we have corresponding veins, like if we have splenic artery, we have splenic vein. So the vein, having corresponding vein, will eventually drain in the portal vein. See, we have discussed somewhere. Splenic vein is the portal vein. And then we have some lymph nodes, celiac lymph nodes and superior mesenteric lymph nodes. Then we have nervous innervation, parasympathetic nervous system and sympathetic. Parasympathetic nervous system having vagus nerve and celiac plexus, and sympathetic nervous system which innervates the obviously the pancreas, and start from the T6 to T11, plus it is via splenic nerves and celiac plexus. Again, we have nervous innervation, sympathetic and parasympathetic. Sympathetic innervation by the vagus nerve and celiac plexus. Parasympathetic innervation with pancreas by vagus nerve and celiac plexus, and sympathetic by C6, C7, C8, C11. Okay, very nice. T6, T7, T8, T9, T11. See, I wrote over here.
Yes.
Via splenic nerve. Plus, it is also having called celiac plexus. So, let's discuss about some clinical features related with the pancreas. What is pancreatitis? So acute pancreatitis is the complication of mumps. We have discussed in our previous class.
Yes.
Mumps having two complications. Conped having two complications. Number one is pancreatitis. Number second is orchitis, inflammation of testes.
Yes.
So in acute pancreatitis we have few signs: colon sign, Gray Turner sign, and Fox sign. What happens in colon sign in acute pancreatitis? Sign means, what does it mean sign?
Observation
Observation of doctor.
Yes.
What are the symptoms?
Patient.
You can see the complaints of the patient. What are the sign mean? What the doctor will observe.
Yes.
In acute pancreatitis, the person will not tell you, okay, doctor, please give me treatment. I am having acute pancreatitis.
Yes, sir.
Obviously not.
No.
You have to have a knowledge and a theory to observe and get that signs like colon sign, Gray Turner sign, and Fox sign. Then you will put the diagnosis like name of the patient, Alireza 2, age, this one,
Yes.
age and gender.
Yes.
And then you have to put diagnosis, acute pancreatitis, according to your clinical knowledge. Yes. Okay. What is colon sign? You will see the bluish discoloration around the umbilicus.
Yes.
That is a colon sign. What is Gray Turner sign? You will see the bluish discoloration at your flank region. This is our flank region.
Yes.
And what is Fox sign? You will see the bluish discoloration just inferior to the inguinal ligament. We have inguinal ligament,
Yes,
right?
yes.
Starting from the anterior iliac spine to the pubic tubercle.
Pubic
That is
tubercle,
inguinal
yes,
ligament.
sir.
So just inferior to the inguinal ligament, you will check. You will see. You can observe the bluish discoloration. That is Fox sign. Fox sign, colon sign, Gray Turner sign are the signs for acute pancreatitis. Okay. Now we will discuss about some pancreatic cyst, that is symptomless. The person will not have any kind of symptoms, but you can diagnose these things when you are doing some ultrasound or some other diagnostic aspects. Then pancreatic pain will refer to the front and back. The most important landmark of the pancreatic pain is belt-like pain. You know,
Yes,
the
yes.
belt.
Yes.
जब बेल्ट लगाते हैं तो वो टाइट करें उसको,
Yes.
मजीद टाइट करें. You will have a pain starting from the front, not starting from the front and from the back also. See, same pain will be patient of acute pancreatitis will be having without belt, but belt-like pain.
Yes.
That's the sign for pancreatic pain. Pancreatic pain, obviously. Then we have annular pancreas, where there is a ring formed, and that ring obstructs the pancreas and the duodenum. Then we have there is a pancreatic resection of the head and neck is possible. Head and neck. And then we have pancreatitis, inflammation of the pancreas. That will leave the fluid in the lesser sac. It is called a pseudocyst. And only treatment of the pseudocyst is I and D. I means incision and D for drainage. Incision and drainage. Pseudocyst.
Yes.
Incision, drainage. There are many problems, many disorders. There is a treatment of child is ID, I and D, incision and drainage. Just have an incision and drain. That's it. Okay. After these things, let's discuss about our last but not the least fourth player, that is gallbladder. It is a pear-shaped sac. What does mean pear? Nashpati shaped sac or a thelly. With capacity of 30 to 50 ml. Normal capacity of the gallbladder is 30 to 50 ml only, but it can distend it to the 50 times more than their normal. Okay, and the function of this gallbladder, it concentrates the bile 10 times. It concentrates the bile 10 times. Obviously, it also helpful for the storage of the bile. And when there is a hormone called cholecystokinin, that will contract. We will talk about here in detail, cholecystokinin later on. Just now, cholecystokinin, what it will do, it will contract the gallbladder, and there will be, bile will come from the gallbladder to the second part of the duodenum. Okay, now we will not go there. We have few parts of the gallbladder. First of all, fundus. It is present at the level of inferior border of the liver. I can show you like this. Suppose this is our dear gland. Which one?
Liver.
Like this. So here we have,
Inferior part.
this is what. Here it is present our dear gallbladder, like this, more specifically. And in order to understand, left hepatic duct, right hepatic duct, then cystic duct, then common second part of duodenum. Are you with me?
Yes,
sir. Okay. Fundus present at the inferior part of the liver and attached with the anterior abdominal wall and present at the tip of the right ninth costal cartilage. right ninth fossa, call it hip. Then we have cystic duct. This 3 to 5 centimeters. This is cystic duct, right? The length of the cystic duct is 3 to 5 centimeter long, and it regulates the bile flow. Obviously, there will be a storage and concentration of the bile, and it will helpful in the flow of regulation of bile flow. Plus, it runs from the neck in the lesser omentum, and it joins with the common hepatic duct. It will lead to the common bile duct located in the hepatoduodenal ligament. Okay, it is worth repeating. I will repeat again over here for you people. Make a better diagram. Suppose this is our liver. From the left lobe we have which duct? Left hepatic duct. It will get bile from here. Then we have from the right lobe we have which duct?
Right.
It will get bile from here. So this is the left hepatic duct and right hepatic duct. They will join together and make which? Common hepatic duct.
Yes.
Then common hepatic duct will join with another duct.
Common
This is what? Cystic duct. Cystic duct plus common hepatic duct will join together and make what? Common bile duct. What is important? CBD, very important. Then common bile duct will join with the main pancreatic duct. This is main pancreatic duct. This is hepatopancreatic duct or ampulla of Vater. It will go to the second part of duodenum with a sphincter called sphincter of Oddi. Okay, and there is no fun in telling this is the main pancreatic duct, right? So the accessory, if this is the pancreas, right? There is a major pancreatic duct, or okay, we'll discuss later on. Maybe we missed something. Obviously, yes. We have discussed about these things or not? We have discussed about ducts? No.
Yes, sir.
There is a main pancreatic duct, which is also called Verson's duct. Okay, I show you like this. Start from the neck, and from here, this is the main pancreatic duct. Then we have accessory pancreatic duct, or also called duct of Santorini. Starts only from here. It will drain into the second part of duodenum. We have minor duodenal papilla over here and major duodenal papilla over here, and the distance between these two papilla is 1.9 centimeter. Okay, so major pancreatic duct you can see over here. It is joining with which duct? Common bile duct, CBD. Okay, and okay. Then what we have missed arterial supply, pancreatoduodenal artery. Okay. हम कहाँ थे? Cystic duct 3 to 5 centimeter long, regulate bile flow and all these things, and joining. Now you know this mechanism, right? Left hepatic, right hepatic, common bile duct. Okay. Then is another terminology called spiral valve of Hester. The mucosa of the gallbladder, it projects into folds, and it arranges in a body of the gallbladder in a spiral fashion in the neck and cystic duct. That is why it is also called spiral valve of Hester. Then we have Hartmann's pouch. This is the enlargement of the neck of the gallbladder by stone, and due to formation of the presence of a stone, there will be a formation of a pouch. That is called Hartmann's pouch. Then we have arterial supply, cystic artery from the right hepatic artery, it's supplying the gallbladder. Then cystic vein, it get blood from the gallbladder and go to the portal vein. Then we have small vein that also lead to the hepatic vein. Then there are lymph nodes called pre-aortic lymph nodes. It gets lymph from the cystic duct. As you know, from the lymph from all over the gallbladder will drain to the cystic duct, and from the cystic duct the lymph will go to the pre-aortic lymph nodes. Now let's discuss about some innervation. We have sympathetic nervous system innervation by the cystic plexus. Nerve root values T7, T8 and T9. Parasympathetic innervation by right and left vagus nerve and right phrenic nerve. Okay, then the referred pain of gallbladder, some clinical features. Referred pain of gallbladder, if there is a problem of the gallbladder, cholecystitis or cholelithiasis, then what will happen? Pain will refer to the inferior angle of the right scapula, not left scapula. Right scapula, inferior angle. If I can so if I can show you, so this is what? Right scapula. Yes. So just below the inferior angle, this is we have discussed about the scapula, right? We have three borders, three angles and three processes. This is the inferior border, rather at the tip of the scapula. So the pain of the gallbladder, see gallbladder over here now. So the pain of the gallbladder will refer to the inferior angle of the right scapula.
Right, yes.
Okay. Now you understand. Okay. अगर आप osteology ना पढ़ते आपको कैसे पता चला inferior angle किधर है, superior angle किधर है, lateral angle किधर है? So these things, step by step you will learn these things.
Yes.
So pain of the pancreas will radiate to the right scapula inferior angle. Okay. इधर रहने दो बस. ठीक है इधर रहने दो. Then bisympathetic fibers and the pain of the gallbladder can also radiate to the stomach due to the vagus nerve innervation. And pain of this gallbladder can also lead to the tip of the right shoulder by the phrenic nerve. Okay. Then there is a hormone called CCK, cholecystokinin, released by the GLT mucosa. When you eat something, it will release by the GLT mucosa and it will contract our gallbladder. And due to the contraction of the gallbladder, how much bile is present in the gallbladder, that will be, come downward here.
Yes.
And it will go to the duodenum. Obviously, it will do its work. And there is a sign called Murphy's sign. Anybody know what is Murphy's sign? Now we are talking about some clinical feature. How you know there is a problem in the gallbladder? So what you do, you simply put your finger just right subcostal margin, and you will ask the patient to have inspiration, or you can say take air inside and hold, breathe in and hold for some time, like. And if there is a inflamed gallbladder, and during inspiration, the wall of the inflamed gallbladder will come into contact with your finger. That is called Murphy's sign. And if someone is having gallbladder inflammation called cholecystitis, then on inspiration, he will having an involuntary grasping condition. It winces it is also called catch in the breath. During breath, there will be pain and person having involuntary grasping and things. This is called catch, winces catch in the breath, that is Murphy's sign. Then we have Caloric Triangle. We have discussed about Caloric Triangle in our previous lecture. The content of the Caloric Triangle is hepatic artery, cystic artery and cystic lymph nodes. Let's discuss about what is Moynihan's hump. This is nothing but just simply tortuous right hepatic artery. This is also called caterpillar term. This is the most dangerous anomaly. Then we are having pharyngeal cap. This is the most common congenital anomaly where there is a fundus is folded like a pharyngeal cap. The fundus of the gallbladder is folded like a pharyngeal cap. Let's discuss about Pringle Maneuver. What is Pringle Maneuver? It decreases the blood flow to the liver. Why? If there is a bleeding persists after post-cholecystectomy. What is Pringle Maneuver? Basically, just think. You remove gallbladder. Okay, removal of the gallbladder is called cholecystectomy. What is cholecystitis? What is cholecystectomy? What is appendicitis?
Removal of appendix.
Inflammation. What is appendectomy? So post cholecystectomy means after cholecystectomy, if bleeding persists, there is no blockage, there is no stoppage of bleeding. Still you are having the patient is having bleeding. You did your job. You think you did it perfectly, but after cholecystectomy, the person is still bleeding. Then you will do Pringle Maneuver to decrease the blood flow to the liver, to decrease the bleeding. How you will do? Pringle Maneuver, it decreases the blood flow to the liver if bleeding persists, or it means if bleeding continues. Post cholecystectomy means after removal of the gallbladder, there will be compression of the hepatic artery and hepatic vein at the Winslow, foramen Winslow, or epiploic foramen of Winslow. We have discussed about epiploic foramen of Winslow in detail in our second part of digestive system. We have discussed its relationships also: anterior, posterior, right and left, and superior inferior. And not only portal vein and hepatic artery at epiploic foramen of Winslow, plus we also compress the anterior surface of the right free edge of the lesser omentum. So this is just a maneuver in order to decrease the bleeding tendency of the person post cholecystectomy procedure. Now let us know what is cholelithiasis. Lithiasis means stones. If it is gallbladder stones, we call it cholelithiasis. There is called 4F in cholelithiasis. There are 4F which lead to the cholelithiasis. First F for fat, Increased amount of fat having more tendency for cholelithiasis. The person having more fat. Another fat for fertility. Fertile. If the person is fertile, having more chances for having gallbladder stones. Other F for females. Females having more tendency to have gallbladder stones. And other F for 40. 40 years of age is most vulnerable for having these things. But males are also having gallstones also. Don't go for 4F only. खुश नहीं हो जाना कि हाँ हम तो मेल है हम तो फीमेल नहीं है तो लेकिन गॉल ब्लैडर स्टोन्स मेल्स में भी होते हैं इन ऑर्डर टू रिमेंबर दीज 4F फॉर फैट F फॉर फर्टाइल F फॉर फीमेल and F for 40 years okay and gallstones or cholelithiasis happens in humans in ox and hog why because there is increased fatty acid content in our bile but it is impossible of having gallstones in dogs in cats in sheep and rabbits. Why? Because the bile content, there is decreased level of fatty acid content in their bile. So it is impossible that dog is complaining for cholelithiasis or a cat is going to a veterinary hospital for having cholecystectomy or a sheep or a rabbit due to decreased content of fatty acid in their bile. Then we have typhoid fever. Everybody knows typhoid fever. What do you call it in Urdu? अंतड़ियों का बुखार टाइफाइड
सूजन हो जाती है
जी जी टाइफाइड फीवर will attack lymphoid tissue bone marrow and our beloved gallbladder then we have Courvoisier law in which if there is an external obstruction of the bile duct will lead to the gallbladder dilatation that is called Courvoisier's law it means if there is internal obstruction of the bile duct it will not lead to the dilation of the gallbladder. This is a law called Courvoisier law. समझ आ गई है? If there is external obstruction of the bile duct, it will lead to the gallbladder dilation. That is called Courvoisier law. But if there is internal obstruction of the bile duct, there will be no dilatation of the gallbladder. Now, last but not the least, let's discuss about bile duct. It forms in the free edge of the lesser mentum by the union of the cystic duct and common hepatic duct, also known as common bile duct. The length of this common bile duct is 6 to 8 centimeters in length. So cystic duct 3 to 5 centimeter. Yes. Common bile duct 6 to 8 centimeter. Okay. There are three parts of the bile duct: upper, middle, and lower. Upper third part of the bile duct is also called supraduodenal part, and it is present in front of the portal vein and to the right of the hepatic artery. The middle third part is also called retroduodenal part. Retro means behind. Supra means above. Para mean around. So retroduodenal part, duodenal part or middle third part of the bile duct, it runs behind the D1. What does mean D1? We have 4 parts of it, right? This is D1, this is D2, this is D3 and that is D4. Level of D1 is L1, D2, L2, D3, L3, D4, L2, again L2. So D4 and D2 also present at the level of L2. Okay, then last but not the least, lower third part of the bile duct or paraduodenal part, the relationship of paraduodenal part with the posterior side of the head of the pancreas and in front of the right renal artery. And if there is a neoplasm or cancer of the head of the pancreas, it will obstruct the third part, that is lower third or paraduodenal part. But in some books, it is written that the neoplasm of the head of the pancreas will obstruct the fourth part of the bile duct. Which books? BDC, BD Churasia or Vishram Singh book. They are telling that if there is a neoplasm or a cancer of the head of the pancreas, it will obstruct the fourth part of the bile duct. But in majority of the other books, they are telling that if there is a neoplasm or a cancer or a tumor to the head of the pancreas, it will obstruct the third part of the bile duct. So only 2 things, BDC और विश्राम सिंह, ये आपने नहीं लिखनी है अपने लेक्चर नोट्स पे, बाकी सारी चीजें आपने लेक्चर नोट्स पे सारी आपने नोट करनी. Is there any question? Let me know.
No sir.
Seriously?
Yes sir.
I told you to write something if you have any confusion.
Everything clear sir.
How many surfaces in our liver?
Surfaces हमने तो पढ़ी थी ना, हमने मिटा दी है. दोबारा से वीडियो दोबारा सुनेंगे तो नहीं उसमें आ रही.
सर जी एब्रीविएशन ऑफ डायम में ई क्या
एक विसरल सरफेस थी और डायफ्रामेटिक सरफेस थी.
सर ई का एब्रीविएशन बता दें डायम में.
एक मुझे बाद में पूछना. एक और थिंग्स है ERCP. ERCP means endoscopic retrograde cholangiopancreatography. This is a very much important thing for the diagnosis and for the diagnosis of pathology and treatment of the liver, gallbladder and pancreas. But it is having a complication. जिसकी हर चीज़ की पॉजिटिविटी और नेगेटिविटी होती है. So ERCP having complication of damage to the head of the pancreas. It can also called pancreatitis. Endoscopic retrograde cholangiopancreatography in order to diagnose any pathology of the liver or the gallbladder or the pancreas. But it can also lead to the pancreatitis. क्या क्वेश्चन था?
Abbreviation of E in there.
Abbreviation of
E. In there.
D for duct. Which duct? Left hepatic duct or right hepatic duct? A for artery. Hepatic artery. B for vein. Hepatic vein. E for epiploic foramen of Visceral or mental foramen. I think आपने second part of digestive system नहीं पढ़ा.
Yes, sir.
दोबारा से सुने. Make lecture notes. And these three parts of digestive system are more than enough for you people. If you put these parts at your fingertips, it is very. I will be very happy, and this is enough for my self satisfaction.
For NLE.
And for NLE, for
Yes,
next PG, I think you will not miss any question related to the anatomy of the digestive system.
Yes.
Any other question?
No, sir.
Seriously?
Yes, sir.
Yes, sir. Thank you, sir.